So excited to have Diana back for another one of our bi-monthly financial Q&As. She saw a need in our community to get answers out to people regarding these financial subjects and decided to offer her services to all of us here. So we want to thank her for that. With that, I'll go ahead and introduce her. Diana is a financial program manager specializing in financial help for multiple myeloma and AML patients. As a professional financial advisor and former caregiver of her husband who was diagnosed with multiple myeloma, Diana perfectly understands the financial issues facing cancer patients. With that, we'll turn it over to you, Diana.
Thank you, Cindy. Thank you all for joining us. This is a very unsettling time, and we wanted to, I'm glad we started this actually before the first of the year, but wanted to provide this as an opportunity for you to ask questions, no matter what those questions may be. We want to, here at HealthTree, be a resource of education, of empowerment to all of our cancer patients. No matter where you are in your journey, we would like to provide the resources, the immediate needs you may have. And with that, there is going to be a QR code. This first time we're adding it to our webinars and my newsletters, where you can use that, scan that, and it will direct you to our Connect group. There, I'm going to be giving you the latest updates on what's going on with healthcare, with everything that may affect you in your journey. So I'd encourage everyone to join that. And if you have friends who are unaware of that or can't do it, you can call our patient navigator and we can get you into these Connect groups. So please take the time to scan that code, because this is going to be a great resource for you to find the latest information that may affect your insurance, your care going forward. So let's get into this. This is going to be a long day. I'd encourage you to take notes. Again, this information will be provided to you for all the ones who signed up for this particular Q&A session. Next slide, please. So one of the first questions, with President Trump now withdrawing from the WHO and NIH, will this cause less research and drug manufacturers declining help with your drug costs? So this is a ever-changing environment. There are some concerns as to whether some of your drug costs may change. There are some things that are already in the works before he even took office, took office here just recently. But we will keep you informed as to what's going on. It may affect the cost of drugs. Some things may be changed, terminated, and maybe put back into place. As you see, there are some things that were changed, but he's reversing some course and some things. Again, if you join our Connect group, I will keep you informed as to the latest that's coming out as soon as I get that information, because I am keeping my ears to the ground as to what's going on. Next slide. So here's a question. My husband is on long-term lenalidomide maintenance treatment. Since retirement, we have qualified for income-based grants, which have completely covered any co-payments. Last year, we sold our home of 39 years and realized a large capital gain, which will put us over the income limit to qualify for these grants. How will this be handled by the grant issuers? Okay, so whenever your income changes and you need to reapply for a grant, they are going to ask you about your income. You may not qualify for that year when your income is above their thresholds. Usually it's between 300 to 500% of federal poverty levels, so you may not qualify for that year because of those large capital gains. I know it's very inconvenient, but that's how they run their programs. And most of them do not go above the 500% federal poverty levels. You may be able to access, you may, and I put that in caps, be able to access patient assistance programs through the manufacturer of that particular drug. So you might want to contact them. Again, they have income limitations, but they may be able to stretch it a little bit. But so you would have to contact them directly. Next slide. Do non-myeloma meds count toward a $2,000 cap? Now, this is what's really interesting, and I think some people have gotten confused as to how that cap is. The cap applies to Medicare Part D or Medicare Advantage plans where you have medicine, medicine or prescription plan attached. That cap, the $2,000 cap, only applies to medications that are covered under your insurance plan. For instance, Revlimid is not covered under every Medicare Advantage plan. In fact, very few will actually be covering the Revlimid. If it is any medication is not covered under your, is not formulary toward in your insurance plan, you will be responsible for that additional coverage or out of pocket for to pay for that medicine. So if it is not covered at all, that is something you're going to be responsible for. If it is in their formulary in your insurance plan, it does apply toward that $2,000 cap. So that is what I've been telling people to really, really look at your plans. If you need to change, you need to change. So really, please be on top of that. And it's not just for your myeloma drugs, it's for any prescriptions that you take. The next slide. How well does Medicare assist in paying for treatment options? Again, that is going to be depending on what type of Medicare you have, whether you have Medicare Part A and B, which is your traditional Medicare only. You will be responsible for that 20% if you do not have a supplement plan, such as a Medicare Advantage or a Medigap supplement plan. But Medicare generally pays for a lot of your programs, whether it's treatments as well as prescriptions, whether it is oral or it is infusion type, and that would fall under Medicare Part A or Part B. If you do not have a prescription plan, you might want to look at getting a prescription plan and a Medicare Advantage or a Medigap plan if you still qualify for one. You can go to the Medicare.gov or CMS.gov and you can review what your particular plan, if you have one, will cover. And you can also talk to your social worker wherever you get your treatment, and they can also assist you in determining what your plan will cover. Next slide. Are there any grants or other financial resources available to assist with the $2,000 copay for patients with multiple myeloma for 2025? There are quite a few plans, but I want you to keep in mind, whatever you get in grants to pay for copay assistance or whatever does not apply to your deductible. It never applies to your deductible. That has been something, a contentious thing that's been in legislation, and it seems to fall by the wayside with all these other things that are pressing. But there are programs that are available. If you have an employer plan, you may be able to get assistance through the pharmaceutical. If you have a Medicare, some pharmaceutical companies will help you, but you have to tell them you have Medicare. They do have Medicare Assist. I know Bristol Myers Squibb has a Medicare Assist, and you have to ask for that. If it's considered a nonprofit, nonprofits have assistance for copay, deductibles, coinsurance, as well as some of the premiums that you may pay, be able to be reimbursed for that. That is the problem with the nonprofits is they're not giving out as much, most of them are not giving out as much money as they used to for grants. And they seem to close quite a bit more frequently than they used to. So I would check on those. I know HealthWell currently is open, but it's a Medicare access. So if you have Medicare, might be able to apply for those based on your income qualifications. We have our financial resources online. I would suggest you go to copays.org or some of the other programs will tell you exactly what grants are open under nonprofits for your type of cancer. Next slide. I just retired and have Medicare Plan A and B, which is your original or traditional Medicare, and also Plan G. I'm assuming that Plan G is you're considering under your Medigap. Is there a way to get plan treatments pre-approved through Medicare? Whenever you talk about pre-approved, you talk about Medicare or any kind of insurance plan, that is generally referencing prior approval, which means the doctor has already suggested this is the type of treatment you need, and you have to get prior approval for that. I would caution you and to warn you that sometimes these prior approvals are taking a while. It could take 2, 3, 4 weeks, and sometimes you may have to go through different types of appeal processes. So if that's something that's getting ready to happen, I would suggest you have that pre-approval done and get copies of that pre-approval as well. But if you're talking about something down the road, in the event you may have to have a treatment, Generally, no. It has to be something that the doctor has actually suggested you get on a treatment plan for. So, according to Medicare, pre-approval is based on a suggested, recommended type of treatment. It's going to be coming up. It's imminent for you to take, and that is considered a prior authorization. Next slide. My question concerns the transplant travel and lodging reimbursement offered by some employers, typically $10,000 per calendar year. In my experience, myeloma patients who will be receiving transplants out of state must first travel months ahead of time for in-person consult to satisfy the prospective transplant team that they're transplant eligible. And months later, they of course travel again for transplant evaluation followed by the stem cell transplant. Is the employer's transplant travel and lodging benefit typically limited only to reimbursement to the second trip, or does it typically also include the first trip? So, employer transplant travel and lodging typically reimburse you by reimbursing employees for necessary transportation and lodging costs when they need to travel to a transplant facility for evaluation, surgery, or post-operative care, including all the treatment in between. So usually, though, their health insurance plan with specific limits, and you said yours was 10,000 of the amount covered, and often requiring prior authorization for eligible expenses, including the travel, airfare, hotel expenses, etc. The details will vary depending on the employer's health insurance policy and the transplant center involved. So, what you need to know, key points for the employer program such as this, is what are your covered expenses, which can include your, like I said, again, airfare, train tickets, rental car fees, mileage reimbursement, and so forth, lodging and hotel. You need to find out what your insurance plan covers. Eligibility requirements. Employers or employees must typically have a qualifying medical need for a transplant and need to travel to an approved transplant facility. They're going to need to know if that is approved under their plan. Prior authorization. Everything you do has to be prior authorized in order to verify that you're actually getting that treatment, you need the treatment, and that you can be reimbursed for it. Again, there are maximum reimbursement limits, and each employer plan that has this attached to their benefit programs have a amount that can actually be used. In your instance, it's $10,000, and you need to provide receipts. So anything you do, you got to provide receipts. So which means, again, this is reimbursement. You have to pay this yourself first and then provide the receipts, making sure you meet all the other criteria, such as the covered expenses, eligibility requirements, prior authorizations, and so forth. So make sure you keep all of that information available to you and copies. Next slide. I am 67 and a half and just selected Medicare Advantage, AARP Medicare Advantage from UHC Texas 005. It's a PPO last June, and then was diagnosed with CKD, anemia, spine issues, and MGUS last fall. I have an appointment with UTSW in February to obtain their opinion, etc. Previously, I have been in really good shape over the years. I am worried that I should not have selected Medicare Advantage and have heard if I move to a state without my current plan, I can select basic Medicare and a supplement plan and I don't have to provide medical info. Should I look at that? Very interesting, kind of complicated. So if you did not choose a Medigap plan when you were first originally eligible, 65, then Medigap plans can deny you. Now, you have Medicare Advantage. If you were to move to another place, you may, depending on the state, some states offer, you can get into Medigap plans at different times. You'll have to check with your state. That will be through the state health insurance program. Every state has it. Just put in ship.org or put in your state that you're going to be moving to and find out what their requirements are. Do not be surprised that because you already have these existing health issues and you are 2.5 years past the 65 original Medicare date, that you may not be able to get a Medigap plan or considered a supplement plan. Again, check with your state insurance, health insurance program to find out what you qualify for in that state that you're going to be moving to. Next slide. Is there a better Medicare supplement to buy when faced with the unknown treatment course for multiple myeloma? The drugs, cell therapies coming out every day. How do you know which insurance carrier is most favorable toward approving and paying these? It's not like you can call and ask them when all you know are the drugs you are taking right now. I totally agree. And you don't know what your treatment is going to be from year to year. When you're looking at the Medicare supplement plans, what you need, they have diagrams, you can see what is actually covered. Generally, the Medigap supplement plan, and I'm not talking about Medicare Advantage, so a lot of people get these confused. The Plan G gives you better overall coverage. Now, you've got to keep in mind that the cost of these plans vary because some of them will not be offering as much coverage as the other plans. That's A, B, C, D, whatever they are. Usually Medicare Part G gives you the best coverage. Again, with each plan, they'll also tell you how they are rated as far as getting prior approvals if needed, and how they cover any problems with getting things paid. There's generally a rating for those. If you talk to your state insurance health program or talk to a broker, they will be able to tell you how those are done. Again, a Medicare supplement you need to buy, best time to buy is when you're first eligible to take out, or when you're first eligible for Medicare. If you have a Medicare Advantage plan within the first 12 months, you can go back to original Medicare and then possibly be able to select a Medigap plan. There are limitations into getting into Medicare supplement plans without having to go through underwriting, without being denied coverage with that guaranteed issue. So those are things you need to keep in mind. Next slide. Why can't pharmaceutical companies provide copay assistance when you are on Medicare? It seems they only do it if you have employer insurance coverage. Now, that is not completely true. It's kind of confusing. If you are, for instance, on Revlimid and you call Bristol Myers Squibb, if you tell them you are on Medicare, they do have a Medicare Assist program. There are nonprofits that have Medicare Assist programs that are open right now, like HealthWell. Theirs is open for Medicare enrollees. So I would suggest when you have that issue with a particular prescription, call the manufacturer of that prescription. We also have those resources in our financial resource page where you can look at those as well as for the nonprofits for you to call them. Again, they may not have it, may not be advertising as much, but a lot of these pharmaceutical companies have access to care, financial assistance, and they will also refer you to programs that can help you with those copay assistance program. But you can be on Medicare and still get help through a pharmaceutical company. Next slide. I had a stem cell transplant approximately 2.5 years ago and have been taking Revlimid since then, which has been covered by my insurance. When I renewed my original Medicare plan at the end of 2024, my current insurance plan indicated that they no longer cover Revlimid. They do cover the generic version, but my cancer doctor informed me that the generic version is generally not available. I could not find any insurance plans that cover Revlimid that are available in my geographic area. I ended up staying with my current insurance plan as there didn't seem to be any better alternatives. According to the insurance site, the cost for Revlimid is approximately $1,000 per day, and the cost for the generic is approximately $90 per day. Since the generic version, which will be covered by insurance, doesn't seem to be available, any advice on how to cover this very significant cost? Again, this is going back to my original discussion before we started. Revlimid has been dropped by a lot of Medicare Advantage plans. And what people are going to have to do, if you cannot find that Revlimid, if it's not available, it will be more readily available in 2026 when it will be produced more because there is patent requirements when a Revlimid biosimilar is coming online. And it takes a couple years, several years before it comes out in full. And there may be other alternatives available on the generic side as well, which should significantly reduce the cost of that generic as well as possibly other Revlimid because they're trying to compete, right? So what I would suggest you do is to talk to your doctor. If you cannot find that lenalidomide or lenalidomide, is to make sure that he does ask for a appeal on this based on what is medically necessary, and if you cannot find the other generic. A lot of people are aware that this generic is not as readily available. So if you can get a appeal done through your doctor, it's that is medically necessary, you cannot find this drug, and this is a drug that you need, and get a prior approval done. Next slide. What other resources beside LLS offers assistance with costs of commercial health insurance premiums? There are several out there. I would suggest you go to our webpage, healthwell.org, and right now it's only for Medicare access, but you need to keep looking at these as the first of the year. Other opportunities may be opening up, copays.org, maybe opening up with additional resources for assistance for any of our blood cancer patients. So I would do that. And then again, a lot of times you'll pay and they will reimburse you for those premiums. Get online and check them out. Be very proactive with this though, because it's first come, first serve. Next slide. If I apply and receive disability, am I required to go on Medicare? My current insurance through my wife's job has great overall coverage with only a $600 deductible, and I don't want to change the doctors and our treatment. So this is a kind of a loaded question. It varies, and it varies on the employer. If you are currently employed through your wife's employer, sometimes even with the spouse and or the employee that may go on disability, they may request you go on and sign up for Medicare. Now, generally, you can only do Medicare when you've been on disability for 24 and in your 25th month, then you can qualify for Medicare, and that is how Medicare works if you're younger than age 65. So the insurance company can require you to go on Medicare if you are over 65, been on disability for at the very least 24 months. I know it's very discouraging, but you can also, while you're doing that, check the Medicare and find out which doctors will be in network. You may find your doctors and your treatment facilities may still be in network with what you're currently having through your wife's job's insurance coverage. Next slide. I have MGUS and have lab work and see a doctor every 6 months. Do I need to do something now in regards to insurance, et cetera, in case I transition to MM later? Don't know what your age is, but don't know if you're on Medicare, if you're on employer or federal, any other like veterinarian benefits. I'm not sure. But what I can tell you is this: you may have MGUS. You know, a lot of people do not transition to Medicare, multiple myeloma later. And so it's very hard to say what to do now versus what's going to happen later, if it even happens later. As we know, insurance regulations, insurance coverage changes even within plans. So if you were to choose something now in anticipation of what you may think happen next year, that may not be the case, or it may not be the insurance you need. So I would say that no matter what plan you're on, just be aware of what you're able to afford and get the best insurance that you can afford in the event you do transition over. If you're on a Medicare A and B, you may want to consider going and taking out, if you already don't have it, if you're eligible, take out a Medigap plan that'll give you more coverage. And maybe you can change, if you have a Medigap plan, change into a better coverage plan like the Plan G. But and no one's clairvoyant. We don't know what's going to happen the rest of this year versus next year, but I would just make sure you're aware of any changes that are going on in the insurance marketplace. Next slide. When will lenalidomide become cheaper than its brand name Revlimid? It is slightly cheaper. But again, it goes back to patent laws or qualifications and restrictions. Generally, when a drug has gone through that several years, when a biosimilar comes out, it takes several years before it can be fully in the marketplace. And sometime in 2026, it's estimated that lenalidomide will be more readily available. At that point, Revlimid will become a really competitor with lenalidomide, and lenalidomide prices may drop as well as the Revlimid. But that is not until sometime in 2026. Next slide. I received copay support from the Leukemia Lymphoma Society 1 year. It was extremely helpful. A staff member at Huntsman Cancer Hospital in Salt Lake City helped me to get it, and I've never been able to do it again. Is there some secret to qualifying for this program? Not really, other than being there as soon as it opens up, and you have to check back quite often because they may close and open throughout the year. Um, and a lot of those programs are not even letting you be on a wait list where they would automatically call you and contact you and everything. So I would suggest you just check it every couple of days to see if they are open. You might want to have, again, a staff member help you at Huntsman Cancer Hospital. You may call them because they're helping other people. They may know when it's opened or when it's not, but there is no secret other than being aware of when it's open and then qualifying for that program. If that one is closed, again, look around and see if there's any others available. Like again, healthwell.org is open. If you're on Medicare, that is open, Medicare Access. And there are several others that are open, but we have those resources again online in our Financial Resource Center. Next slide. Are there any other copay assistance programs I could qualify for? They all have somewhat similar qualifications, such as income limitations or income requirements or restrictions. But you can check into several. I know several people who are quite a few patients who have more than one copay assistance program. They may be working with LLS and HealthWell or LLS and copays.org, and they use them for different things, maybe for getting reimbursed for premiums, the others for paying for copays, deductibles, other out-of-pocket expenses. But yes, you can do that. Again, check online and see which programs that are available to you or that are open. Next slide. What you see are the effects of the new administration. What I do see for sure, 100% sure, that everybody's confused. There's a lot of uncertainty. We don't know what all is going to happen. It's just keeping um, our eyes and ears out as to what's happening, what's changing, what could change. I would tell you it's a day-to-day thing. If I were you, I would keep up on it. Again, if you don't have the time or the strength to do that, I am going to be I have our Financial Connect site where you can sign up for that. I will be putting the latest information out there. I will keep you up to date on what's going on if it's going to affect you. But I would tell you that there are changes, and it's changes always changes for every administration. This one seems to be a little bit different, a little bit more, I guess things are kind of topsy-turvy right now. Eventually, things will settle out. We don't know what those things are going to be, but I would suggest you stay on top of it. We'll be glad to assist you. We have financial coaches that'll be glad to assist you if you have any financial concerns. And again, if you will sign up for the Financial Connect on Financial Connect, I will be putting updates on there so that you will be aware of things that are coming on that may affect any of our cancer patients. It's not just for multiple myeloma. So who should you speak to about possible financial assistance options? Again, going through our financial resource page, talking to our financial coaches. We have some excellent financial coaches that can assist you. And it's not a one and done thing. We are here, like we said, for lifetime to assist you with whatever questions you may have. You may have a lot of questions now. Do not feel that you can only talk to them once. Do not feel that you only have to have one coach. You can have several coaches for different things. But if you don't ask for a coach, you're not going to get the answers that you may need, answer those questions you may need answered. So please reach out to us. That is what we are here for. Next slide. Can you explain balanced billing and if it is common for myeloma patients? Balanced billing is when you get a bill, your inpatient, in-network patient. I'm going to talk about in-network right now. Generally, when you are going in-network for treatment, there is a street charge, and then there is what the doctor charges and what they are the negotiated price after insurance pays. There may be some leftover. Insurance may not pay everything that is billed. What is different is called that balance, the balance that is left. If that's not part of your copay, co-insurance, which is that's outside of that, that's something you're going to be responsible for anyway, then it's considered balance billing that's left over. If it's inpatient, that is that you should not be billed for that. I mean, in network. If you go out network, then depending on what kind of treatment you get, if it is a, let's say for instance, an ambulance, ambulances are generally funded or owned by the state or the local government, you may get balance billed for that because it's not for that bill for that service because it's not covered as much on your insurance. It's not controlled by the balance billing acts that went in 2022. So make sure you're going in network and making sure that if you are getting paid a balance billed for those things, to check with your insurance company to make sure that that is actually, in fact, something you need to pay for. It can be confusing, and there are errors that are always made in billing, whether it's balance billing or just regular billing. 80% of bills are incorrect, especially if you're spending time in a hospital because there's so many more things, nuances, things that come into place with billing. So check with your insurance company, look at your EOBs, and make sure you're being billed correctly. Next slide. In 2022, I was diagnosed with smoldering myeloma. My labs have been stable during this time, and I have not had any symptoms or treatments. However, given the unpredictable nature of multiple myeloma, I need to be prepared in case treatment becomes necessary. In April, I will be switching over to Medicare, and I want to make sure that I pick the right supplemental plan and the right drug plan because I'm hearing that these drugs are really expensive. Yes, these drugs are really expensive, and I would suggest you talk to someone in your state, again, SHIP, a lot of people don't seem to understand just how valuable they are. There's no cost for you to talk to them. That's a state health insurance program. They can go through a lot of these programs with you. They can tell you based on the medications you're on now or what you may be anticipating for next year, what the best plan is for you. And they will go for the cost, what drugs you're currently on that may be covered or not covered, what's on formulary and not. And remember, those things can change as far as being on formulary or changing in their changing as well in there. So you can make all the best laid plans and things may change next year. If you're going to get a Medigap plan, I would suggest you do that Medigap plan when you look at all your comparisons, Medicare Advantage as well as Medigap, make sure that you're getting the best plan for you before you get a Medicare plan and you can't drop it and go back into Medigap. So I would look at everything, talk to someone, reach out to me. I'd be glad to assist you in understanding how this works. And you can also sign up to any of our financial coaches on our coach website. Again, I would suggest everybody get into our Connect pages to let you know what's going on with Medicare, what's going on with ACA, what's going on with any of these Medicare plans, because there's so much in turmoil right now. I'll be glad to assist you and weed out everything that I can to assist you in making the right decisions. Next slide. What financial assistance is available for patients who need CAR-T or biospecific therapy or other treatments which require caretakers and their patients have no care partner and can't afford to hire a caregiver 24/7 as required to approve the treatments? If you talk to the provider who's going to give you that CAR-T, a lot of times the CAR-T may be covered through assistance programs or through your insurance. If you need a care partner, Medicaid can be an assistance and Medicare can be assistance depending on how you need that assistance. I would talk to your social worker or your oncology nurse navigator at your place where you're getting treatment to ask them what could be available to you when you go home. Because yeah, you will need a caregiver during some of these times, and they are aware of what is available to you based on the type of insurance you have. You can also reach out to your pharmaceutical company to say what they have, or maybe you have state state or local assistance that may be available to you. And you can call 211. Everybody has that, where you can call 211 to find out what kind of additional assistance may be available in your state or local to provide you with a care partner to help you during that treatment process. Next slide. What are the requirements to be approved for a grant to help with costly treatments, whether they be oral infusion for retired patients who have no caregiver or income? If you have no income, usually you have Medicaid and you would qualify for a lot of the programs through your pharmaceutical companies. That would help for your infusion, your oral medications, and that will be Medicaid. And generally, it will pay for most, if not all, of your oral and infusion care. If you are on Medicare, again, it's the same thing I told everyone earlier. If you have no income, it's generally you're generally going to fall into Medicaid. And some places may be Medicaid and Medicare dual coverage. Um, I would check with the plan that you have, talk to your doctor's office, your social workers, because and your social workers and your oncology navigators, they will help you with finding um, the coverage or the assistance you may need. Again, reach out to us as financial coaches. We can help you as well with some of the programs that we know that are available for you. Next slide. In December, my insurance company, excuse me, in December, my insurance company wasn't going to cover Revlimid in 2025, but then they did cover it, probably because the generic lenalidomide wasn't available. I assume this applies to many insurance plans. What will happen in the coming months? If if you, I'm assuming that is a Medicare Advantage plan. Again, a lot of them drop the Revlimid because there is a biosimilar with the lenalidomide, but the lenalidomide has not been flooded into the market because of patents, and that will generally supposedly open up in 2026, sometime in 2026. So I don't know what's going to happen in the coming months. We don't know. I can only let you know that I am watching this, and in our Financial Connect page, if you'll join that, I will be able to give information as it comes out, as it's coming out on a weekly or whatever basis, so that you can be up to date as to what's happening, so you can make the best decisions for yourself. Again, reach out to our financial coaches as well. Next slide. In March, some generic lenalidomide will be available, but only 30% of patients needing this drug will get it. Who exactly will get it, and what happens for the other 70% who don't? I.e., will the insurance pay for Revlimid? Again, I don't know where you came up with the 30%. Um, if you are needing Revlimid and your lenalidomide is not available, you should be able to go to the Bristol Myers Squibb, have your doctor do a prior authorization based on medical necessity that you need, getting a prior authorization so that you can get the medication, the Revlimid, if the lenalidomide is not available. So the goal is that you will have either the lenalidomide or the Revlimid, but you will have the treatment that the doctor finds is medically necessary for you. But you may have to take additional steps, getting that prior authorization if the lenalidomide is not available, showing it's medically necessary, and go through possibly an appeal process. I would not wait because you don't want to have a lapse in coverage or lapse in treatment while you're doing this. A lot of doctors may be getting backed up because a lot of people are having the same questions, and it's not just with Revlimid, it's maybe other medications as well. So I would suggest you get this taken care of if it applies to you, not being able to find the lenalidomide in your area, and you're going to need the Revlimid. Next slide. Oh, we got through those. So here again is that QR code for you to please join that to join our Connect group. That is where you're going to get the latest information of what's what's happening in legislation, what may be happening with your health insurance, what may be happening to anything that may apply to your health, no matter what blood cancer or cancer you may have. I would suggest you scan this, Join our group and you will get the updates as they come in. And then you will also access other programs we have, such as our Cure Connect, our clinical trial program, which is coming out. It's great, which will be more specific or personalized to what your needs may be. And I will keep you up to date with anything financial that may affect you. Thank you for joining our group, and I look forward to the Q&A. This is February, April, and then our webinar every other month. Next one will be coming up in March on our new financial topic. Thank you again.
Okay, thank you so much, Diana. I really appreciate your level-headed answers. I know there's a lot that's up in the air. There's worries for everybody. But the thing that I want to emphasize that Diana also said as well is she's going to weed through all of it and get those answers for you through the Connect page. So there was a question about getting that QR code. I hope you're able to scan it. Otherwise, we will send it in the follow-up email. I also will link the financial resource page that Diana mentioned, where you can find all of the information about grants and other financial resources that will come out in that follow-up email as well. So we've got a few more minutes for some more questions. So I'd like to encourage you to jump in that Q&A, ask those questions. There was one question about if their question was previously entered into the event, if we'd address that. We should have gotten to it. So if you did not get that question answered, go ahead and put it in the Q&A. We did update the questions today, so you should have gotten all of those. One other comment from one of our coaches that says with Revlimid, they can request a 30-day emergency supply while they get their doctor to write a request to give them the brand through their drug plan. So just want to put that out there as well. Is that something you've heard as well, Diana?
Yes, it is. I'm sorry, I forgot to mention that. That keeps you, that assists you on staying in treatment while that prior authorization is being pushed through.
Okay, perfect. Thank you so much. So don't fear, know you've got things and possibilities available to you. So just make sure you reach out and get what you need as needed. So we'll start off with our first question. It says, I had a subsidy from Bristol Myers Squibb for my Revlimid for the past 3 years. I was not on Medicare, and in each instance, their subsidy wiped out my out-of-pocket maximum. They gave me a card with the subsidy. Can you speak to that?
Yes, there are cards where where you can use it for your to pay for your out-of-pocket expenses, and they will still have that. Now, if you are on an employer plan, you'll generally find things a lot easier to go through when you're going through pharmaceutical companies. And Medicare, some of them will only take people who have Medicare or Medicare access, but you need to ask for Medicare access if you have Medicare, and they will provide the same kind of services, the same kind of grants to you. And I want you to keep in mind that any grants you get, whether through the pharmaceutical company or through nonprofit, they do not apply to your deductibles. That deductible will remain in place until you pay it. And so if you have medications that are not covered by insurance, you'll still need to meet that deductible for those prescriptions that are not covered. So please be aware of that.
Perfect, thank you. Next question comes up with Revlimid again, asking if the issue with Revlimid is only with the Advantage plans or with standalone Part D plans also.
Part D plans as well. Yeah, it's a lot of insurance. It's Medicare has been, I think, highlighted because there's been a lot in news about Medicare and how a lot of them were sold. And again, whenever you buy anything, I'll say anything, I don't care if it's a television, buyer beware. You need to know as much about what you're buying as possible. And you need to ask questions and find out if there's other better options available to you, and be aware of buying them through some brokers, because brokers do not always give you all of the products that are sold or at insurance plans in your area. They have to pay for each plan for each insurance company, and that's a cost out of their pocket. They may take a few select ones out of there, and they get paid that is how they get paid through the insurance company for plans they sell. So you may not have, or they may not be presenting you with every plan available, and there may be a plan that they're not offering you that may be better for you. But But yeah, I would be aware of what you're buying and be aware of how those things can change because some insurance plans have dropped off medications during the year or they dropped off your treatment facility during the year. So in that case, they should notify you within 30 days so that you have the option or the time to get another insurance plan.
Okay, thank you. Next question says, some states are working towards single payer health program. Do you think that would improve the situation for myeloma patients?
Good question. Loaded question. Single payer, I don't know. That has been something that's been on the forefront for quite a few years in different places. So don't know. We just don't know, especially with this climate with so many things going on. I cannot answer that.
Perfect. It's hard to see what's coming in the future, so thank you. Next question says, I show about 1,000K on my tax return. Is that too much income to qualify for grant money?
That's kind of confusing as to what that question is asking. Can you repeat that?
Yeah, sorry, and I said 1,000. I show about 100,000 on my tax return. Is that too much income to qualify for grant money? So I'm not sure if they're getting, I can't imagine 100,000 return. Maybe that's
Okay,
income.
generally what they're looking at is they're looking at your gross adjusted income. That may be their adjusted income. So there are pharmaceutical companies that can assist people even if they have incomes over 100,000. It depends on how many people in your household as well. Because they're looking at FPL, federal poverty levels. That's based on how many people are in your household. So I would suggest that they can call, if they're looking at pharmaceutical companies, call them and see if you can get assistance through them to pay for copays or deductibles. Now, copays, but I would generally, when you talk about nonprofits, that may be a bit much. And again, I don't know if you're talking about your adjusted gross income or what income you're referring to.
Okay, perfect. You replied and said only one person. Does that change anything?
That does.
Okay, perfect.
It makes it probably more difficult.
Okay, perfect. We got one last question about our QR code, and I will get that answer into the follow-up email. I'm not able to scan it right now to give you the walkthrough, but we will make sure we've got step-by-step and make sure you're able to get into that Connect group and have that available for you. So it looks like that is all of the questions for today. Again, want to thank you, Diana, for all of your wisdom and all of the preparation you take in making sure that we get the most correct information and are able to navigate all of these different financial changes. So thank you so much.
You're welcome.
Perfect. So we'll go ahead and close out the webinar today. As you leave the session, of course, you'll have the opportunity to take a short survey. We always appreciate your feedback. It helps us know how to better get those topics covered that you need covered and how we can better serve you. So here are just a few of our upcoming events. We've got a lot of events for the different blood cancers coming up on Friday. At 1 p.m., we have how BRCA and other gene changes influence multiple myeloma risk, treatment, and your family's health. So make sure you register for that if you're in our multiple myeloma community. We also have for our CLL community, how CLL weakens your immune system, what you need to know. That'll be a webinar starting at 3 p.m. And then we'll also have a podcast release, latest advancements in CAR T therapy at 12 p.m. Eastern. So we have many more virtual and in-person events in the works that will be announced shortly. The link to sign up for any of these posted events is down at the bottom of the slide and will be sent out in the follow-up email as well. I'd like to again thank our sponsors, Pfizer, Regeneron, Johnson & Johnson, GSK, Karyopharm, Bristol Myers Squibb, AbbVie, Sanofi, Adaptive, and Genentech. And finally, I just want to say thank you again for helping us build strong blood cancer communities. I've added my email to the slide, so please don't hesitate to reach out if you have any questions about HealthTree or any of our programs. I appreciate all of you, and I hope to see you again at our next event.